ask that folks start taking their seats. Those who are out in the solarium, if you want to start heading back in. Give it a couple of seconds.
I need like the theater lights up there.
Oh. Should I pop my head out?
Oh, yeah.
Okay. I'm Jess Berman. I'm a nurse practitioner at Cancer Genetics and Prevention Clinic, and I see a lot of familiar faces out there. Thank you so much for taking the time and coming. We're so excited to have you. I also, before I forget, want to thank our speakers for taking the time. I know you've all had busy weeks, you've got families, you've got friends, and you're here because you're passionate about your work and your Lynch syndrome knowledge, and thank you for sharing all of that with us. So, without further ado, our first speaker, we have Dr. Laura Graham, who's a medical oncologist here at the university, who's going to talk to us about urinary tract cancers and men's health. Thank you, Dr. Graham. All right. Hopefully we're feeling refreshed after the break. Thanks for having me. This is such an awesome event. I'm so glad to see everyone here in this room. I am a medical oncologist, so I specialize in the medical treatment of cancer. So I'm the person that you never want to see, but my focus really is on cancers of the urinary tract, and that includes bladder cancer, upper tract cancer, and prostate cancer as well. And this is sort of an emerging area in the Lynch space. So we're learning a lot more about how Lynch impacts your risk of developing these cancers and the biology of these cancers. We're learning how to treat these based on mutations in Lynch genes. So I'm kind of excited to share what's been developing. So to orient us, I'm going to start with prostate cancer. I'm going to talk a little bit about the prevalence in Lynch syndrome. And then I know we've done a lot of this prevalence so far today and kind of the scary stuff. And then I'd like to talk about what we're going to do to help either screen and detect or reduce the risk of developing prostate cancer. And then I'm going to talk a little bit about treatment. We'll move then into urothelial carcinoma. So that's bladder cancer, other cancers of the urinary tract. We'll talk a little bit again about what it is, the prevalence, screening and awareness, and then some unique considerations for treatment. So we'll start off with prostate cancer. So again, with all the caveats that we just heard about, that these risk estimates are fluid and not precise, but generally about 28% of men with Lynch syndrome will develop prostate cancer. So out of every 100 men, about 28 will develop prostate cancer in their lifespan. That is compared to an 11% prevalence that all men in the general population will develop prostate cancer. So prostate cancer, even in the general population, is actually a very common cancer among men. And then in this prospective Lynch syndrome database, this was the risk by gene of developing prostate cancer by age 75. And this has been fairly consistent across studies that MSH2 seems to have the highest prostate cancer risk, so about 23.8% there. And then you can see the relative rates of the other genes, including MSH6 and PMS2, which actually look about on par or even less than the general population. So what do we do about it, and will screening be helpful? So this is the IMPACT study. And I know that diagram may be a little bit hard to see, but this study prospectively enrolled men who had known mutations in MLH1, MSH2, and MSH6, and who were aged 40 to 69. And they also included matched non-carrier controls, and they did annual PSA screening. So essentially the plan was you would invite men to participate, you would get a first PSA sample. If it was less than 3, you would be informed of the result and keep getting your annual PSA for at least 5 years. And then if you were over 3, you would be referred to a urologist, you would have an evaluation and likely a biopsy. And then depending on what that biopsy showed, you would either get appropriate treatment, get closer surveillance, or go back to the annual PSA. So what I thought was really interesting, so just in the first screening round, so that first time that people were getting their PSAs detected, there was 303 carriers of MSH2. They found 13 cancers. So these were people that hadn't been screened before and were just being screened because of the study, and there was a 4.3% baseline cancer rate in that population. In the non-carrier matched controls, they found 1 cancer out of 210 men. So that was a rate of about 0.5%. And then MSH6, similarly, they found 4 cancers out of 134 carriers and no cancers in the matched non-carrier controls. And then at least at this baseline, there was no cancers detected in MLH1. So this is still early, and we're still waiting on all the longitudinal follow-up, but I actually find this quite striking that even just at baseline, this is what we're finding. I think the other thing that's really important to know and understand is prostate cancer is not just one disease. And I know this is a complicated table, and I'll get to it in a second. But when you read about prostate cancer in the New York Times or on the general press, there's been a lot of talk about PSA screening. Should we do PSA screening? Does it actually impact outcomes? And I think the important thing to know is that that really applies, number one, to the general population who's at an average risk of prostate cancer. And number two, there is a difference between low risk, what we call Gleason 6 prostate cancer. That is the cancer that colloquially everyone says, well, you'll die of something else. And a Gleason 9 prostate cancer that has a high risk of being diagnosed metastatic at presentation. So the reason that matters, or the reason I bring that up, is if you look at this table, so the one non-carrier who had cancer had a Gleason 6. So this is essentially on a scale of 1 to 10, how normal or abnormal is the cancer. Gleason 6 is kind of that first score that's cancer, but it's it looks more like a normal prostate. And so this was a Gleason 6. If you look at the carriers, the majority of them are being diagnosed with intermediate or high-risk prostate cancer, Gleason 7, Gleason 9, Gleason 8. So these are cancers that we think would cause problems in relatively short order if they went undetected. So again, not to fearmonger, but I think there's just a lot of misinformation about PSA screening in general. So I want to emphasize that prostate cancer is not one entity. If you're at higher than average risk, PSA screening is definitely recommended, at least in my mind. So what does the NCCN say? So that's our National Comprehensive Cancer Network. And so they publish various screening recommendations. There's actually an entire section on prostate cancer early detection. And because there's some discrepancy in the various preventive task force and other things as far as PSA screening, they're a little bit cagey. But so for people with mutations in Lynch-associated genes, the recommendation is to discuss potential benefits and harms of prostate cancer early detection starting at age 40. If the PSA is less than 3, repeat testing at 1 to 2 year intervals. If the PSA is greater than 3, consider workup and biopsy. And I realized I should have said this earlier, but PSA stands for prostate-specific antigen. It is a highly reliable indicator in the blood of some pathology in the prostate. So whether that's prostate cancer or whether that's benign enlargement of the prostate cancer, it's very specific to prostate cells. Okay, so we talked about screening, we talked about risk. How can we reduce the risk of developing prostate cancer? Probably beating a dead horse at this point, but physical activity is our most evidence-based recommendation. So in one retrospective study, there was a significant reduction in risk of developing prostate cancer in men who spent more than 9 hours a week in physical activity. And then lots of systematic reviews and meta-analyses suggest that the amount of total physical activity you do is significantly related to a decreased risk of prostate cancer. And then likely related to that is managing obesity. So in this prostate cancer prevention trial, which was a longitudinal study of men at average risk for prostate cancer and looking at what went into their, whether they developed cancer or not, those in the highest range of BMI or weight had a significantly increased risk of high-grade prostate cancer. And then related to some of the stuff we talked about with colon cancer, men in Western countries in general have much higher rates of prostate cancer than men in Asia. And so one hypothesis is that difference in diets, like the higher fats, animal proteins, and Western diets may contribute. So shifting gears a little bit, we heard earlier that in Michigan, most of the people that were tested were women with breast cancer. So seeing as I see mostly men with prostate cancer, I wanted to figure out how we could increase the rate of genetic testing for these men. And so what I said was, and with our awesome genetic counselors here as well, we said when somebody comes into our multidisciplinary clinic who is eligible for testing, can we identify them ahead of time? Can we, when they come into our multidisciplinary clinic, which is when they see our radiation oncologist, our surgeon, me, if they have to, while they're waiting for all these providers, why don't we show a video that Lisa Koo and others helped develop on genetic testing while waiting for the providers? And then can we administer the genetic test right there and then, instead of waiting for a referral to genetic counseling? If we do that, if there's positive results, then we could arrange an expedited appointment with a genetic counselor. And I'm actually really proud of this. So in 2023, which was the year before we implemented this, about 19% of men who were eligible for genetic testing actually completed testing. And then in 2024, after we rolled this out, we went up to about 63%. So imperfect, but that's a pretty significant jump. So I would like to talk a little bit about kind of special considerations in metastatic disease. And again, I know this is not, it's a hard thing to talk about because I think this is when the cancer is spread outside of the prostate. It's a place that nobody wants themselves or their family members to be. But are there things we can take into account for men with Lynch syndrome that might be different than the average population? And so just as a little bit of background, sorry, I forgot this was animated, but prostate cancer is androgen dependent, meaning it is very reliant on testosterone and other androgens to grow and divide. Most of that testosterone comes from testicles. There's a little bit that comes from the adrenal glands, peripheral tissue, and actually prostate cancer itself gets really freaking smart and it starts making its own testosterone. So that's sort of the baseline of how prostate cancer grows. And so I think of prostate cancer as being on a continuum. So on the one hand, there's localized disease. We often treat that with radiation, plus or minus lowering of testosterone or surgery. But for high-risk disease, about 50% of people still relapse. And that can either be non-metastatic, so we're just detecting it based on PSA, or metastatic, but very responsive to lowering of the testosterone with something that we call androgen deprivation therapy. However, resistance inevitably develops. And when that happens, it's a terribly named term, castration-resistant prostate cancer. But this, I didn't make it up, I'm sorry. But this is the kind of that end stage, like the what men are at risk of dying from. So we need more things, like hormonal therapy, that's great, that was revolutionary, but now what? And so you heard about immunotherapy. Okay. So immunotherapy, you've got the tumor cell, it's upregulating this ligand called PD-1. It binds to a T cell that has PD-1 on it. And this binding, it's a signal, it tells the T cell, don't worry about me, I'm normal, don't respond to me. If you can block that signaling, so binding to PD-1 or PD-L1, then that can activate the immune system against the cancer. And you saw that slide from the New England Journal. We've had such amazing responses in other cancer types. But in unselected men with prostate cancer, the response rate is only 3 to 5%. And if you take biopsies of these tumors, the immune system is literally just sitting around the tumor and hasn't actually gotten itself in. Okay, I'm going to come back to that. So we know that about 3% of prostate cancers are mismatch repair deficient, so probably associated with Lynch-associated genes. And would these folks respond better to immunotherapy than the average person with prostate cancer? Again, related to all the things we've talked about. If you've got lots of mutations, you're presenting novel proteins to the immune system, is that going to help with response? So we looked, actually in collaboration with the University of Michigan, at men who had Lynch syndrome or mutations in Lynch-associated genes, who had metastatic castration-resistant prostate cancer and received an immunotherapy called pembrolizumab, which again blocks that signaling between the T cell and cancer cell. And we found a response rate of 53%. So what this plot is showing you is the best PSA response to immunotherapy. And anything below that 0 line is a decrease. And we generally consider a PSA 50 response rate, meaning a decrease in PSA of 50% as a response. But what was really striking was that there were several men whose PSA went to undetectable, and they had these long, durable responses. And when we compared our data, so on the right there with data from other institutions, the response rates were pretty similar. So a response rate of around 50%. I want to be mindful of time, but I also want to share one anecdote with you. So I think just to kind of personalize the numbers a little bit. So when I was a fellow, I think this was 2018. So this was actually before the approval of pembrolizumab for cancers with Lynch-associated mutations. And I had a gentleman that I was sharing with my supervising physician attending. And we had tried everything. So we had tried every single treatment for prostate cancer. And we got to the point where we were going to try an investigational CAR T trial, which was totally untried in prostate cancer, had a high risk of, adverse effects and probably a low chance of working. And I said, hey, and again, early on in the whole sequencing era, and I said, hey, have we ever actually looked at the genes of the cancer? And we realized we hadn't. So we sequenced it. And he had mismatch repair deficiency, a germline MSH2 mutation, and a high tumor mutational burden. So we were like, great, we're going to give you pembrolizumab. Wrote for pembrolizumab. Insurance said, nope, we're not going to give it. And we said, you really need to give it. Here's the reasons why. And they said, nope, we're not going to give it. So then we applied to the company and they agreed to give it to us for compassionate use for free. And he had a complete response. So his PSA went to 0 within one treatment. His tumor just disappeared. It was one of the most profound and sort of life-altering moments for him, obviously, but also for me. And so again, just want to contextualize that and provide a little bit of hope that we're learning, we're evolving, and I think that the immune system is probably the way to go, especially in Lynch syndrome. All right. Whew. Okay, we did prostate cancer. Let's talk a little bit about urothelial cancer and urinary tract cancers. So urothelial cells are specialized epithelial cells that line the urinary tract. And so anything that touches urine, so that starts in the kidneys, that goes to the ureters, and then the bladder and the urethra, lined by urothelial cells. Upper tract carcinoma, so things that involve the urinary cells in the kidneys or the ureters, seem to be pretty associated with Lynch syndrome. So about 20% of upper tract urothelial carcinomas are Lynch associated. Granted, it's a relatively rare cancer overall, and so I think that's partly why there's been some delay in recognition of that. But that's, I think, pretty well accepted at this point. And then bladder cancer is lower tract, so it's anything that arises in the bladder. And that can either be non-muscle invasive, which is incredibly common across even the general population. So that's superficial cancers that don't actually invade into the muscle, or it can be more invasive, and these are the cancers that are at risk for spread. And so what are the actual risks of urothelial carcinoma and Lynch syndrome? So this is looking at the German and Dutch national Lynch syndrome registries. And over about 2,000 gene carriers were followed. And essentially, this is showing you up top the bladder cancer risk by gender in panel E, and then in panel F by specific mutation. And I realize this is quite small. And at the bottom, other urothelial, so non-bladder cancers. And to me, what's striking is there's a slightly higher risk in women, actually, which is different than the normal rate in the average risk. But upper tract specifically has a much higher risk than the standard population. And then that blue line is MSH2. So similarly to prostate cancer, that seems to be the gene with the most risk of developing one of these cancers. So what do we do about it? Right now, there's no clear evidence to support surveillance for urothelial cancers and Lynch syndrome. Part of that is because we don't really do surveillance for urothelial carcinoma generally. However, you can consider doing surveillance in people with a family history or individuals, especially with MSH2 variants, and you could decide to do an annual urine analysis. So what that's looking for is really looking at blood in the urine, but we have no prospective data to show that that actually changes outcomes. So if we're not going to screen, or even if you are going to screen, what should we be looking out for? So what are things that you shouldn't ignore and you should talk to your provider about. And so blood in the urine is the most common sign of urothelial cancer. And that can either be what we call gross hematuria, which just means you can see it with the naked eye, or microscopic hematuria, so it would only be detected on a sample. And then other symptoms are a need to urinate often, a strong urgency to urinate, pain if you don't have an infection, and then that sensation of not fully being able to empty your bladder, or if things are really progressed, being totally unable to urinate. So how do we reduce our risk of developing urothelial cancer? So we know that smokers, so people that smoke, have a 3 to 4 times higher risk of urothelial carcinoma than those who don't. So if cigarettes are part of your lifestyle, trying to reduce that would significantly decrease your risk of developing a cancer. And then again, exercise can reduce inflammation, improve immune function, and may reduce cancer risk. So I'm running out of time. So what I want to say is this is our current landscape for treating bladder cancer, what we call localized bladder cancer. And it involves chemotherapy, removal of the bladder, and then immunotherapy generally. And this is all changing. But right now, through one of our National Cancer Institute funded multi-institutional studies, we're going to be looking at, for people who have mutations in Lynch-associated genes or other genes that or markers that may predict response to immunotherapy, actually giving immunotherapy up front and then seeing if we can avoid doing a bladder removing surgery at all. So I think that's gonna be really exciting. And here's where I'll also put in my plug that we need NIH funding and we need NCI funding. And as much as we can continue to advocate for that, I think that'll be important. Okay, so awareness is empowering is my key takeaway. I think a lot of a lot of the stuff we talked about today is talking about risk and all these things, and that's really scary. And just being aware of what you can do about it, I think, is empowering. And then you got to talk to your physicians about screening, especially in urinary tract cancers. There is no one-size-fits-all approach. And then we've got a lot of cool treatments that are coming, including treatments to basically take the immune system and pull it into the tumor. So lots of cool stuff. I'll stop. I would love to take questions later. So thanks.
Thank you so much.